Okay, so let's talk about the trochlear nerve. Because it is often a confused topic to be discussed. So, what is trochlear nerve? So, trochlear nerve is basically the fourth nerve. Okay, so it comes out. It comes out of the midbrain at the level of the inferior colliculus. Okay, this is a cerebral aqueduct. So it will come out here and it will decussate. Okay. And then it will pass. This is a sella turcica. So pituitary gland is lying over it. And here is cavernous sinuses. On the lateral side of the cavernous sinuses, it passes and it goes into the superior orbital fissure to supply the muscle. Which muscle? The muscle which is called as superior oblique muscle. Okay. Now this is the muscle. Here is a pulley which is called as trochlear. It passes through that pulley and it inserts into the lateral inferior portion of the eyeball. Here again. So here is the pulley. From pulley it goes into the lateral and inferior portion of the eyeball. Now it is quite obvious, okay, that now the main question, okay, let's come to the main question. Often you are confused about whether this is the right or this is the left one, or this is the left or this is. So let me get this clear for you that this is the right trochlear nerve. Okay, this is the right trochlear nerve. Now you will ask me that how come this is the right trochlear nerve, but it comes when it originates from the left one. Okay, let me get this clear for you that we name this nerve after they come out of the midbrain. Okay, so they come out of the midbrain on the right side, so that's why we call it the right nerve. And this nerve originates from the right side originally, but because it originates here and it is on the left side, so that's why we call it on the left nerve. Okay, so whenever you get a question that your right nerve is having some problem, so which muscle will be disturbed? So you will say right superior oblique muscle will be affected. Okay, not left one. And if they ask you your left nerve is affected, so which muscle will be affected? So you will say because left nerve supplies the left superior oblique, so left superior oblique will be having problem. Now the confusion is when they ask you if the right nucleus, okay, they are mentioning this one. Okay, so this is the right nucleus, okay, of the trochlear nerve, and this is the left side nucleus of the right nerve. Okay, so basically from the right nucleus your left nerve originates, and from the left side nucleus your right nerve originates. So if there is a problem with the nucleus, okay, if there is a lesion in the nucleus, then you will have right nerve problem and right superior oblique problem. But if there is a problem in the right nucleus, then you will have left nerve problem or left superior oblique problem. Okay, so you have to make sure that whether they are asking about the nucleus or they are asking about the nerve. If they are asking about the nerve, it's ipsilateral, okay? There is no confusion over there. Right nerve supplies right superior oblique. But if they ask you about the nucleus, then there is confusion. If they are talking about the right nucleus, because you know that the nerve decussates here, and after decussation it comes out. So you have to make sure that if it is right nucleus, it is giving origin to the left nerve, and if it is left, then it is giving origin to the right nerve. Okay. Now, I guess this problem is clear. Okay. Now the next problem is, now let's come to the eyeball part. Okay. Now the eyeball part has also some confusion. Okay. So first thing is that you have to make sure that what kind of muscle action is associated with superior oblique. Okay. So superior oblique, suppose this is the muscle, okay, and here is the pulley. So by moving through the pulley, it comes and supplies the lateral inferior portion of the eyeball. Okay, so this is the eyeball. It comes and supplies the lateral and downward portion of the eyeball. So just imagine when it contracts, when this muscle contracts, it will move the eyeball inside. Okay, so here it is the eyeball. So it will internally rotate the eyeball, or it is also called as intorsion. Intorsion. So either it internally rotates the eyeball, or the movement is called as intorsion. Okay, by contracting this muscle. Which is this muscle? Superior oblique, which is supplied by fourth nerve. This is also a mnemonic called sulfate. Okay, superior oblique supplied by the fourth nerve. Now the first one is the internal rotation or intorsion of the nerve. Okay, made possible by the superior oblique. The next one is when it pulls the eyeball. Okay, so the eyeball will be moved downward as well. Okay, so the next thing is when it moves there, it internally rotates. Okay, so when it internally rotates, oh look, it will internally rotate the eyeball. So the eyeball will come down and will also abduct. So it will come down, the eyeball will come down, and it will also be having an abduction as well. Okay, so it will come down and it will abduct as well. So normally there are three movements, eye movements, which are mainly controlled by the superior oblique. So there are going to be three problems. Okay, so suppose your trochlear nerve is not working, so the trochlear muscle supplying the trochlear nerve supplying the superior oblique will not be working. So you will get three problems. Okay, so you will get three problems. Now, if you understood these three problems, you are going to get every question solved properly. Now, the first thing is, I told you, let's start with the lesser one. Okay. Now, okay. First of all, think as if the patient comes to you, okay, and your supervisor asks you that, okay, first tell me what are the movements that are supplied by the superior oblique. So the first thing you are going to say is the abduction. Okay, abduction. The second one is internal rotation, and the third one is downward movement of the eye. Okay, so basically this superior oblique is used when you are climbing down the stairs or you are reading. Okay, you are looking down. Now the supervisor second question will be, okay, so how can you clinically diagnose the patient with trochlear nerve palsy? Okay, so you will give the answer that basically the trochlear nerve or the fourth cranial nerve gives supply to the superior oblique muscle, and this superior oblique muscle is responsible for the movement for all these three movements. Okay, now the main question that your supervisor will ask is that on the basis of these three movements, which one of them is more important? Okay, you got me. So I mean to say that which group of muscle is very much important, that without that specific movement or without the specific muscle, your specific movement cannot be initiated. So those two are internal rotation plus your downward rotation. Okay, these two are very specific for superior oblique, but the abduction one is not so specific. Now let me get this clear for you. Okay, so now the first one, now we will discuss about the pathology. So you have got three problems. Okay, I will explain all the three problems. The first one is the abduction. Abduction is when your superior oblique muscle is not working. So this is a pulling and this is a superior oblique. Okay, what will happen? You won't have internal rotation, downward movement, and as well as abduction. So now this abduction, this is the down. So this abduction. So first of all, you have to remember that your abduction moment is supplied by two muscles. One is called a superior oblique muscle. The other muscle responsible for the abduction is which one? Lateral rectus. Lateral rectus. Okay. Now the lateral rectus is more powerful. Okay, so because you are having some deficiency of superior oblique or you are having abnormality of the superior oblique, now you will think that you will make lateral movement of the eyeball. Okay, so suppose this is your ear, so movement towards your ear will be difficult, or lateral movement will be difficult, or abduction will be difficult for you. Why? Because you are lacking superior oblique. Okay, but no, because the lateral rectus is more powerful, okay, this will compensate the abnormality of superior oblique. So lateral rectus, there will be somehow difficulty with the lateral portion, or lateral, there will be problem with the abduction of the eye, but still your lateral rectus will compensate it. Why? Because it will be normal. Okay, so based upon the abduction, you cannot possibly differentiate the abnormality or the pathology in the superior oblique. Okay, so if your supervisor asks you that, okay, out of the three abnormality, you have to diagnose this patient on the basis of abduction, so then you will say that unfortunately, because of the lateral rectus, okay, compensating the lateral or abduction of the eyeball, I am not able to differentiate it. Okay, there will be little slightly problem, but not as big that you can conclude on the basis of that. The second problem will be, now these two, the remaining two are very important. Okay, the second one will be downward movement. Okay, now again, suppose this is the eyeball and the superior oblique is attached here, and there is a trochlea. Now this is the superior oblique muscle. Okay, and this is the eyeball. Okay, now so the eyeball, so suppose there is abnormality in the superior oblique, or there is lack of supply from the trochlear nerve, so your eyeball will not be able to move internally, so will not be able to internally rotate, as well as downward movement, as well as abduction. Abduction we already covered. Okay, now we are talking about the downward movement. So for downward movement, you have to remember, so downward movement is basically supplied by two muscles. Okay, the first one is superior oblique muscle. Okay, the second one is inferior rectus. Okay, now, okay, this is very important. Now just Just focus on the eyeball. So this is your eyeball, and here is the superior oblique muscle attached through trochlea. Okay, so this is trochlea and this is superior oblique muscle. Now, the inferior rectus is attached here, okay, here. You see that it is not attached vertically or down the eyeball. It is rather placed in this sort of position, okay, where it can push it down to this angle, with this angle, not downward like that one. Okay, I hope you people understood. So because of the angle of the inferior rectus, now, okay, now just remember, if the superior oblique is also powerful here and the inferior rectus is also powerful here, okay, and so they both contribute to the downward movement of the eye, eyeball, okay. But here is one trick. If the eyeball is in lateral or in the abduction position, okay, in the abducted position, okay, so the inferior rectus will be highly responsible for the downward rotation or downward movement of the eyeball. But if the eyeball is in the medial side of the cavity, so in the adducted portion, okay, so let me make the adducted. So suppose the eyeball is adducted, okay, this is the superior oblique, okay. Now just concentrate on the inferior rectus, okay. Now you see that inferior rectus cannot, will not be able to pull the eyeball downward. Why? Because you know here, look, here is contract, here it can contract, but it is already contracted or relaxed in a position, okay. You can see it has no more control over the eyeball moving downward movement, okay. So the main muscle here is now responsible for the downward movement is superior oblique, okay. So if your supervisor asks you that, okay, now if you just have to diagnose this patient's trochlear nerve palsy on the basis of his downward movement, okay, so what you will answer? You will say to the patient that, okay, there is one solution. I can diagnose this patient on the basis of his eyeball downward movement. What you will ask the patient is that you will relax his inferior rectus, okay. So you will try to relax the inferior rectus, okay, and you will try to put all the power, or you will try to give all the power of the downward movement to the superior oblique, okay. Now what you will do is you will ask the patient that please look towards your nose, or please, okay, suppose this is your nose, or please adduct your eye, please adduct your eyes. So in order to adduct, or in order to diagnose his trochlear nerve palsy just on the basis of his downward movement, okay, forget all the other things. There are 3 abnormalities, forget all 3. Just remember, or if your supervisor asks you, just diagnose him on the basis of downward movement. So how are you going to diagnose him? You are going to relax the inferior rectus first, okay, and put all the or give all the power to the superior oblique to do the downward movement, okay. So what you will do is you will ask the patient to adduct his eyeballs. So when he will adduct his eyeballs, you see here So suppose here is nose, so he has adducted his eyeballs, and by adducting the eyeballs, you have, what you can do is you relax the inferior muscle, or your inferior muscle is in such a position that it cannot push the or pull the eyeball downward. So all the power goes to superior oblique. If the superior oblique wants, he can push the eyeball downward. Okay. Now, so in many questions, what they ask you about is that they tell you that okay, there is a problem. The patient is having a problem. Okay. So the patient is having a problem. He notices double vision. He notices double vision when he looks towards the opposite side or like this. So mostly you have to focus on this portion. Okay, on this portion. That whenever the patient looks at the normal position or adducts his eyeball, then you can see that there is a superior oblique abnormality. Now, how can I look at the abnormality? Now look, this is your normal eye, and this is your problematic eye. Or so when what you do is, so this is your, so when you adduct the eyeball, okay, what you do is you tell them that okay, look down. So this will normally look down, but this will not be able to look down. Why? Because all the power during adduction process, all the power is with superior oblique, and the superior oblique is not function. So this patient will not be able to look down, and while this will perfectly look down, and he will have diplopia. Why? Because one will be looking here and straight to you, okay, and the other will look down, so you will have diplopia. Okay, I hope I made this clear. Now, the third problem. This was very important, okay. And which kind of diplopia? You will see vertical diplopia. Vertical is when you have a ball in your hand, okay, and you throw it, and you see two balls vertically. This is called as vertical diplopia. Horizontal diplopia is present in oculomotor palsy. Okay, but this is horizontal, but this is vertically. Okay. Okay. Now we will be discussing about the third problem, which is the last problem, which is the internal rotation. Okay, which is the internal rotation. Now, as you people know that this was eyeball, this was connected here, superior oblique. When this is contracted, this muscle is contracted superior oblique, it will move the eyeball inside, okay, which is called as internal rotation, okay, or intorsion or internal rotation, okay. Now, so if the, forget all the three, just remember this one. Now, if the professor or your supervisor asks you that just diagnose him on the basis of internal rotation problem, just diagnose him on the basis of internal rotation problem, how are you going to diagnose him? Or if he tells you what is the best way to diagnose him, or which muscle is the main muscle, if you cut off the nerve supply, which muscle is going to be defected or affected by the nerve supply. So you will say that okay, superior oblique, the main function is internal rotation. So there will be lack of internal rotation. Superior oblique does the internal rotation, okay, and opposite to it is the inferior oblique. Inferior oblique, what it does is it does the external rotation. It does the external rotation. Okay. So if your superior oblique is not working, your internal rotation is not working. So what it will do, the inferior oblique, on the other hand, will push the downward because this is the normal side and it will have more power over the abnormal one. So so the superior oblique will not be able to internally rotate the eye. So the normal, which is the inferior oblique, okay, it will externally rotate the eyeball, or which is also called as extorsion. It will do the extorsion. So what you will have in this eyeball, so normally suppose this is your eyeball, okay, this is your eyeball, and for reference purposes we put these two arrows. These arrows shows, especially this one, in the middle one, this shows that you are looking straight, okay, you are looking straight. Now because I told you that it will have externally rotate the eye, now what will happen is when your eyes are externally rotated, okay, so you see the middle line deviated externally, okay, but this one will remain the same, okay, this one remain will remain the same. Now what happens? You will see diplopia here. Why? Because the angle, both the angle are different. One is looking at this side and one is looking to this side. So you will see vertical diplopia. Okay, there will be vertical diplopia. Okay. So what the patient will, when the patient comes to you, he will tell you, the doctor, over the period of time, I have come up with a solution. So you will ask him what? So he will say, whenever I tilt the head to the opposite side of the lesion, my diplopia vanishes. Okay. Okay, suppose here is the problem. Okay, here you can see. Now, this will be the two eyes of him. Okay, so suppose here is a problem and there is no problem over here. Okay, there is normal. So look, just let me show you with this arrow. Okay, this arrow is straight, which means this is normal and this is abnormal. So what the patient does is that the patient will tilt his head on to the opposite sides. This side is having a lesion and it will tilt his head to the normal side. Okay. Now what he will do is, so this is normal with patient. Okay. When he tilts his head, this one now, because he tilted his head, this will remain the same. Okay, this one will remain the same. Suppose we took this one and this one will come here. Now look at this one. So now look, this one remains the same, but this one will accommodate with this one because you have tilted the head. Now with the tilting of head, this eye will compensate and it will normally look this side, but this was abnormal. Now both of their vision will be at the same angle, so their diplopia will vanish. Okay, so the only treatment will be when they tilt their head to the opposite side, their diplopia will be vanished. This will remain the same but this will accommodate itself with the tilting of the head, so their diplopia will vanish. Same is on the same case will apply on the other side of the head. Okay, so this is it.